You're listening to The Revolution of Regenerative Medicine, a podcast with me, Dr. Gregory Laurence. So I did touch on a couple examples of some of the things that we've seen good efficacy for and some of the areas that we hope to see increased efficacy. But I think maybe some anecdotes are helpful. The first one that I already hinted to was the amazing thought that somebody with multiple joint degenerative disease, whether it's autoimmune arthritis or even osteoarthritis, wear and tear arthritis, can, after one treatment, be pain-free almost immediately and continue to be pain-free for a year is just an outstanding development. You know, I think patients not too many years ago didn't have some of these great antibody-type drugs that we have that are so helpful for Crohn's and other autoimmune, and to marry those drugs with the ability of your own cells to heal you just really is a game changer in the area of medicine. So one of the stories that probably influenced me as much as anything, as I know a lot of us are just sickened by the fact that a lot of professional athletes, maybe even in the days before they were really paid well, really put their bodies through a lot. And the focus right now is what happened to their brain, but I think that their entire bodies really were ravaged. And I think what we're able to do with our post-concussion patients is nothing short of a miracle. So as a general rule, anytime I hear from a patient, I talk to these patients at some meetings, I've talked to doctors who routinely treat post-concussion patients. The incredible thing is how reliably post-concussion patients respond to cell surgery. And you can arrive at some conclusions on that. Concussion is just one way that damage happens to brain cells. And we know there's lots of other ways that damage happens to brain cells. And so it's not surprising that some of these other conditions also are responsive to cell surgery in a good number of cases. But one of the stories that I heard that was just incredible firsthand from the treating doctor was an NFL football player who had been in a skilled position for 15 years. So that's a pretty good, successful football player. I don't know his name. We probably all would know his name. But he had been retired from the NFL for 15 years, and he was at his soccer game of his daughter's, and he was turned to the game, and a soccer ball hit him in the head. And because he had had a concussion on the average about once a year his entire career, he was in a damaged state in which for the last 15 years since his retirement, he had taken a muscle relaxer, a sleeping pill, a Percocet, and an anti-inflammatory every single day. And he got hit by just a soccer ball, and he was in the ICU. So when he finally did wake up, they said, well, we really don't want to keep you. You know, our concussion protocol is that you just go home and be quiet. And, you know, this thing's just going to kind of get better if it's going to get better. There's not really much to do. There is a lot of talk in the world of neurology about maybe more actively managing concussions and not just passive management, but that's a whole other story. So this guy does go home, and somebody that was aware of what happened to him told him that he should call one of these doctors that works with concussions, and he did, and the doctor said, you need to come in my office now. So the patient came in, and they immediately took him to the procedure suite, did an adipose harvesting procedure, did the processing, which takes anywhere from 2 to 3 hours, and in this case gave the patient his own cells into an intravenous deployment. And the patient then went home and was sort of lost to follow-up, but returned 6 months later with an ankle issue and said, hey doc, can you do something with your magic cells? And the doctor said, wait a second, I haven't heard from you for 6 months. You know, how have you done? Well, so the football player says, well, let me just be honest with you. Every single day that I've woke up, I have laid in bed with my eyes open, afraid to get out of bed because I thought this is going to be the day that my headache comes back, and it still hadn't come back. So there's obviously an amazing amount of repair that just one treatment can do to the brain. And that is a rather typical story. While we can't make promises, and there's certainly nothing close to 100%, improvements in post-concussion patients like this are oftentimes dramatic. And I think that we're going to have new protocols down the road. I think there's going to be a responsibility for the professional athletic associations to make sure that their players are able to have access to this type of technology and this type of treatment. So really, really neat stuff going on. I do want to mention the contraindications. The contraindications would include being a smoker. Smoke is just so devastating to cells that are trying to survive and live that we consider it to be an absolute contraindication. Now, a smoker can stop for 2 weeks and they're a candidate for the procedure, but otherwise they're not a candidate. Another thing that would be a contraindication would be somebody who has advanced cancer. The exciting news is they are going to be using this type of technology. There's a company called STEM Immune that is doing amazing things with using your own cells to sort of using like as a Trojan horse, bringing the oncogenic viruses to the tumors. And I've seen their initial data, and it is absolutely, I understand how complex cancer is. And so going through medical school, I thought, all these fundraisers trying to get the cure to cancer, they're crazy. It's just too different. There's too many types of cancer cells. For the first time ever, I actually can foresee that they're going to have the ability to stop the growth of the majority of tumors by seeing how they were using these cells to basically bring these oncolytic viruses into the tumors. Absolutely incredible. And so, but in my practice, probably any cancer would be something that would be a contraindication for me, but advanced cancer in most practices, we're just not there yet. And then the other thing would be just if the patient can't accept the fact that they might be a non-responder. Now, we can promise them that we just don't see, there's no harm. And that's the neat thing about this, is that we haven't hurt any patients doing this. There've been a couple patients that got a couple funny rashes, like they had some kind of a little immune thing going on, but those were very self-limiting. And really, at the end of the day, it's just one of those crazy things. When you think of what the side effect profile is to most drugs, this is just like, it's an amazing thing. So the other thing I want to mention is that I plan to start a multidisciplinary team here in Tennessee. The members that you need to do this, even though in some cases you could go in and see one doctor and everything could get done, depending on what the deployment needs to be. Lung patients can actually inhale these cells through a nebulizer. They can be placed into an IV, which is commonly going to augment almost any treatment. Like, I don't think I would ever have an orthopedist inject a knee or an ankle without also half of the cells going into an IV, because they just do so darn good at getting to the problems. And a lot of times people don't have one issue in one joint, it's a multi-joint or multi-organ issue. So giving it in the IV is a great way to do it. There's a really, really good surgeon who's a friend of a neurosurgeon colleague of mine that I know well from New York, and his name's Chris Dumas, and you can Google him. He is doing a really, really cool deployment of these cells to the brain. A lot of guys are placing it into like a spinal tap and putting it into the cerebral spinal fluid in through the back. So kind of like getting an epidural or a spinal for anesthesia. But Dr. Dumas doesn't believe that because of the weight of the cells that they're going to circulate very well. So what he's done, he does now you're good when in 20 minutes you can put basically a straw down into the brain, into the ventricle with basically a cistern, a reservoir that can receive a little butterfly needle. And so treatment after treatment after treatment, you can go back, pull out cerebral spinal fluid and do testing. You can give the patient their cells every month straight into their brain, just into the reservoir that he's put right underneath the skin on the head. So this is called an Ommaya reservoir, and so I know that I'm going to be referring patients to Dr. Duma, and a lot of times I may recommend, due to travel restrictions, they might want to have their first treatment intravenous, and depending on how they do, they may want to go for the 20-minute brain surgery. I've been told that a good neurosurgeon can place an Ommaya reservoir in, doesn't have to be in the hospital, they can do it in an office-based setting, which is really, really great when you look at the third world and how we could get some of this care to people. So the Ommaya port, a really, really neat reservoir that can help us when patients need a really high dose. Again, we don't have these protocols all worked out right now, so we don't really know whether it's better when somebody has a brain injury to give them their cells in through an intravenous or through straight into the ventricle, or both. Another deployment would be the interventional radiologists are going to be our best friends, because oftentimes they, using fluoro or other more sophisticated imaging, will they can put a needle right where they want along the spine and be able to treat painful conditions. Well, the problem is if they're just a millimeter off and they get into an artery, you're paralyzed. So the great thing about stromal, and oftentimes they're injecting anesthetic agents, steroids, and the great thing about SVF is that if you get into a vessel, it doesn't matter. It's not going to clog everything up. You're not going to get paralyzed. So I look to the time when it becomes the standard of care, when you can use something that's just as effective as steroids, and we haven't proven it yet, but a lot of physicians in their own experience have seen efficacy that was as good or better than steroids. And why would you give a risk to a patient of them being paralyzed when there's almost zero risk by doing it this other way? So I'm talking about an interdisciplinary team. You're going to have your surgeon that can harvest the fat, that would be me, the one that's willing to make a diagnosis, review medical records, and give a patient this office-based point-of-care procedure, that's me. But having an interventional radiologist is important, having orthopedic surgeon is important for some of the joints, and then of course we're going to be starting to partner with neurologists and cancer doctors, and all specialists really in the future, so that one doctor that might not be proficient in harvesting or doesn't want to go through, just wants somebody else to provide the stromal vascular fraction, the cells that are needed in the extracellular matrix as well. That can just be provided to the doctor that needs it. So it's really, really a neat time. It's a time for us to really collaborate among physicians and not worry so much about turf, and kind of make sure that we work appropriately through anything that's a regulatory issue with a focus on patient safety. And what I want to do is introduce a little bit of you guys so you can ask me some questions, and I think you guys probably realize that there were some things that I didn't say, and so I'm going to let you guys fill in the blank. Thank you for listening to this episode. Be sure to subscribe to my podcast, The Revolution of Regenerative Medicine. I'm Dr. Gregory Laurence, and I look forward to you joining me again soon.